Hello and welcome to Positive East Staying In Together. Tonight we've got Dr Vanessa Apea with us. She's a consultant physician with extensive experience in healthcare, academia and business sectors spanning the UK, North America and Ghana. She recently received the NHS Windrush 70 Award for services in contributing towards improving in health equalities here in the UK. And she's a consultant in genitourinary and HIV medicine at Bart Hospital. She recently completed a study in July 2020, which indicates that there is a higher mortality from COVID-19 in Asian or Black compared to white participants. Vanessa, welcome. It's great to have you with us.
Thank you so much, Greg. Great to be here.
Lovely. So this study that you recently completed, this is hot off the press, so it only came out in 2020. Can you tell us what motivated you to carry out the study, and more importantly, what did you find?
So, yeah, thank you. So, as COVID was evolving, what we were seeing is, and nationally, that the numbers of people that were affected, that were from Black and Asian and other minority ethnic groups, seemed to be unexpectedly higher than we would have thought. And when we say that, it's because if you look at the number of Black and Asian minority ethnic people within the population, you would expect them to be affected at a similar level as in the general population. But what we saw is that they were affected at a far higher level than expected. And because of that, myself and other colleagues within Bart's Health thought it was really important that we understood what was happening locally. So we then looked at the data at Bart's Health hospitals and looked at those that were affected and diagnosed with COVID, and we looked at their outcomes. And what we saw was that those from an Asian and Black background had higher rates of death at 30 days than those of white ethnicity. So there was a definite difference there. And particularly as East London was so affected by COVID, it was just important that we understood what was happening, described it, so we can look forward and to think about how we respond now and in the future.
Great. So some Black and South Asian communities are disproportionately represented with long-term conditions. Can you tell me, do other countries with large ethnic minorities see similar patterns to the UK?
So, yeah, so I think one of the things that's really important is that not all countries record ethnicity. So, sometimes it's not captured as well as it should do. But we did see in other countries, so looking at I think the biggest and actually one of the saddest cases that we see of this is when we look in the United States and we look at those that were disproportionately affected by COVID. It is those from Black communities and other minority ethnics, such as Latino communities. So we've seen that significantly there. We've also seen in other parts of Europe, so within France as well, we saw that those from minority ethnic backgrounds had higher risk of infection and negative outcomes as well. So we've seen it in a number of countries.
Okay. So why do you think then that East London was hit so bad? Can you tell us what you've discovered about East London and why you think the cases of COVID are so prevalent in this area?
No, and I think, yeah, definitely, and it's something that I'll come on to as well in the presentation. So I think that when we look at East London, one of the beauties of East London is that we are one of the most diverse communities in terms of ethnic makeup. So we're extremely diverse. And also, we also have high rates of deprivation within East London as well. And it's a really mixed borough. So you've got pockets of really high affluence, and also you've got pockets of really significant deprivation. And when we look at COVID and we look at the communities that it affected more, we did see that in those communities that there was high levels of deprivation, and what that deprivation meant. So that deprivation meant that many more people were less likely to be able to adhere to social distancing, and there were we often talk about multi-generational households. So there was a number of people within certain households. A number of communities were in jobs that were more people-facing, so they didn't have, cautious of the word luxury, but they didn't have the opportunity to make a decision that actually I can't work with people face to face, I will stay at home. They had to be on the coalface doing those key worker roles that we all were so reliant on over lockdown. And so what you see is that with all of those factors coming together, so largely the social factors, that was a significant part of the outcomes that we saw. But again, I'll talk about that in more detail in the presentation.
Great. So do you have any advice for people about the best way that they can reduce or at least limit the risk of acquiring COVID-19 and therefore avoid these more damaging risks just to their general health and life? What changes can we make apart from the ones that we're already aware of by the government's information?
No, definitely. I think that, I always think it's worth remembering what we should be doing and what we've been mandated to do. So yes, it is that structure of making sure in terms of washing hands, the use of masks in public areas, etc., and limiting our social interactions. But also, I think what we've seen as well is just about the importance of both maintaining our physical health, but also our mental health and well-being as well. So what I encourage people in COVID is about, as far as possible, in terms of our diets and encouraging healthy eating, encouraging taking those walks and exercise, because again, it doesn't just help our physical health, it also, what we're seeing is that it helps our mental health and well-being. And within COVID, I think the impact on everyone's mental health and well-being has been significant. And when we as we go through COVID, that impact is just becoming more and more palpable. And so one of the biggest things I think is a community is just looking after each other and reminding us that it is fine that we feel this way, but how do we support each other to minimize these feelings and move forward?
So in your research, what changes would you like to see the government make to policy and advice that it's giving out to Black and South Asian communities?
Well, I think that's a really important question, and it's one of the important things is and again, speaking as a Black woman, when you see a statistic that affects you, you want to be sure that the powers that be are acknowledging, responding to it, and keeping a constant monitoring of it as well. So I think that's one of the key things, is making sure that we are holding the government to account to say, right, we've seen this, are we keeping track of it? Do we know what is happening? Are things changing? So that we can pick up further concerns sooner rather than later. I think that it's really important that when we look at the messaging that is brought out, that we make sure that we maximize its dissemination into communities, and being really vigorous about and rigorous at making sure that we consider different languages, we consider different educational levels, we consider different digital exposure, because there are so many levels in which many communities, and as we're talking about them, Black, Asian and minority ethnic communities, that may be at a disadvantage. So the responsibility of the government and wider society is to make sure that that information is accessible to all and that all the interventions are accessible to all. I think that, you could get me on a soapbox on all the different things that could be done, because I think one of the biggest things about social distancing, as I've said, is that some people don't have the opportunity. They live with many people in a household. So if you then ask someone who is a train driver and has been exposed, and you say to them, actually, you shouldn't be going home, you need to be self-isolating, where are they meant to self-isolate? So it is considering about how we put those structures in place. Yeah.
Right. I know you prepared a presentation for us this evening. We're all very keen. Yeah. Before we start that, can I just talk to you about vaccines? Because we're hearing a lot of talk about vaccines coming out in November next year. When do you think we'll get a vaccine? And in the UK, will people from Black and South Asian communities be prioritised in giving the vaccines before the rest of the community?
No, thank you. I think that vaccines is like a topic in it, a massive topic in itself. And I think that, first of all, there is what it's important to say. There is a lot of work happening in the background to develop and create a safe vaccine for all. So there's lots of work going on there, as we know. The exact timing of that and when it will be rolled out, etc., I'm hesitant to say. What I will say is what we're seeing is that things are accelerated. So in the same way that you saw in lockdown how we went from a society that barely used Zoom, barely used Microsoft Teams, we just shifted completely to that being our main source of communication. So things are happening at a pace. But for me, what I think is really important until the vaccines come out is making sure that within all communities and within Black and South Asian and wider ethnic minority communities is that we get that information out there and we keep people updated about what's happening. Now, in terms of your question about prioritization, it's really important and I think it's really relevant. But I think for me, within Bart's Health, we're doing a lot of work in sensitizing the community, because I don't know how you personally feel about vaccines, etc. But when you say the word vaccines, it evokes such varied emotions. So some people are like, yeah, I want a vaccine. It needs to come out. We need to move forward. Some people are like, not on your life. I don't want to touch it. I don't know how, it's going to be made so quickly. I don't want to use them. And I think that particularly for Black communities, there is a lot of mistrust about vaccines. And the issue is, in terms, and not just vaccines, of trials. And I think the issue is that mistrust is well placed. So there is a lot of examples and unfortunate and really upsetting, frustrating, and really disappointing episodes in our history where minority groups have been exploited in studies. And, one would be the Tuskegee study, which is related to syphilis treatment. So it was in Alabama sharecroppers and in poor Black men and Black communities, and they were monitored for syphilis. And when syphilis treatment came out, they weren't told there was treatment for them. And so the treatment was actively withheld so that researchers could monitor the outcomes of syphilis. And so when people know of that and are aware of that, you completely understand where that anxiety comes from. But on the same token, I think with COVID, what we have seen is that our biggest armor will be vaccines. And so what we need to do is, if we are going to move forward, we need to ensure that the vaccines are safe, and they're safe for everyone. And if people of all communities don't participate in the studies and don't take up the vaccines, then what we're going to see is, again, unequal rollout and response to the vaccine, and also response to COVID. So there's lots to think about, and I think it's important that people are made aware, given the full and accurate information to make an informed decision as to whether to take it. But it's really important that everyone gets involved in knowing and understanding, and also participating as well, for it to be successful, I think.
Thank you. Just before we continue, I'd like to welcome Beatrice Nebula, who works for HIV and Prevention and Testing Outreach Team. She's going to be joining us now. Welcome to you, Beatrice. So
hey, Beatrice.
Before we go into your presentation, we're dying to see this. Can I ask one last question? Do you think that any good social reform will come out of COVID in the long run?
Hi, Dr. Vanessa.
Hi. Good to see you.
Great to have you in here.
Thank you so much. Greg, you were saying about, do I think any good things are going to come out of COVID?
Talk about all the rapid change that we're going through. Is it all bad news long term?
No, I think that I think we all feel it, that bad comes with good and good comes with bad. And so there are lots of, I call it COVIDitis. So there are some things that would have taken us months and years to put into place. And I think the NHS is a perfect example of it, in terms of some initiatives that we may have perhaps ruminated a bit more on. COVID has accelerated that and brought that through. And so I think there are positive things. Harnessing technology and expanding it has many positives to it. But the thing is, when you are putting anything in place, you've just got to be mindful that you are making sure that no one is left behind, and you are actively looking at that. And I think so, whilst we embrace the positive elements, because on a personal note, if we don't embrace the positive, it feels really oppressive, everything that's happened. So we should embrace the positive, but it's just making sure that we are actively making sure that we are pulling people in and drawing people in and supporting them in a way that works for them, and not just imposing one way. Everyone has to feel a part of it, and one size doesn't fit all. We know that, so we need to be really proactive within that. And I think on another personal level, I think whilst it has been really emotionally draining, a lot of the experiences that have happened through COVID, because you can't move through COVID without looking at the whole social justice movement that has also risen through it, and also with Black Lives Matter. And all I can say is that the conversations, the acknowledgement, all we need to do is really not lose that momentum and move forward with it, for it to become and maintain a positive. So I think there are definite opportunities, but it's just about being really intentional in using those opportunities and just making sure that we support everyone within that.
Great, fascinating stuff. All right then, Vanessa, can we now move on to your presentation that you prepared?
Perfect. This is where technology could fail me, so bear with me, but I will. I think we're on it.
So today I'm just going to be talking about some of the things that Greg and I have been talking about just now, is about looking at ethnicity, COVID-19 and HIV. Next slide, please. And so I think that when we think about COVID in itself, one of the things that just is really striking about COVID is that it hits all of us. It's hit all of us at the same time. And that's really quite a unique thing to happen in society, when we all feel really palpably affected by an infection or a pandemic. And I think that when we're looking at COVID-19 and ethnicity and HIV, I've just put this diagram here because I think it's really important that whilst we describe what we're learning, every person's experience of this intersection will be unique to them, like anything. But what is so striking about COVID-19 is that as it is so new and we're feeling it all right now, it is really raw. And as I just said, that we are still learning and trying to understand people's experience at this intersection. Next slide, please. So COVID. So I think that one of the hardest things about COVID is that it was the great unknown and it still is the great unknown. The things rapidly evolve and there's been an overwhelmingly massive amount of information that we've all had to digest at the same time. And we are learning how best to give that information and the volumes of information to receive. And I don't know about anyone listening, but you know, I've had to mute many WhatsApp chats because I was being continually bombarded with loads of different theories of what to do, when, etc. And I think all of that as well really adds to that bubble of anxiety and fear, etc. And so, and again, that's really unique that so many people are feeling that at that time. And with COVID-19, there is a real focus on individual behavior and in individual decision-making. So whilst we're given this information, we all have to, it all impacts our individual behavior. And that behavior then affects and intersects with our close network and then the wider network and society as well. And the real focus on individual behavior has been about social isolation and social distancing. In addition to the hand washing and masks, the social distancing was a massive part and still is of our prevention approach for COVID-19. But I call that the armor of prevention that we've got for COVID-19 a real privilege. Many people won't see it as that, but I feel that to be able, as I've alluded to before, to be able to socially distance means that you're not in a forward-facing, outward-facing key worker role. That means that you can, if you are in a role that is reliant and is 0 hours, so you make a decision every day, right? Do I stay home and get no money whatsoever? Furlough is not an option for me. Or do I go out to work, but run the risk of exposure for myself and my family? Being at home and having access to online and telephone services, that is a real privilege to be able to have that access. And I think, you know, I'm always cautious to use the word selfish because it's always got really negative connotations. But within COVID, we have had to be selfish. We've had to think about what does this COVID mean for me as an individual, not just my family, not just anyone else, but me right here. And there was a point at the peak that it felt that, you know, that decision of life and death was right there in front of us every day. And I think that's something really important to recognize. Next slide, please. And then when we look at ethnicity by itself and not looking at COVID or HIV, the experience of different ethnicities is really different. And there are a number of societal inequalities and a number of policies and infrastructure in our society. That means that many communities and many different communities and those from minority ethnic communities do not experience or have the same level of opportunity or positive experience as those of particularly white ethnicity. So there is the concept of structural racism that is palpable and experienced every day. And there are societal inequalities. And I think in health healthcare, we know that there are many, if we look at outcomes of a number of diseases and conditions, so if we look at diabetes, if we look at different cancers, we will see, and it is repeatedly seen, again, also in sexually transmitted infections as well, that those from minority ethnic backgrounds, including Black, Asian, and other minority ethnic backgrounds, their experience is they will experience more adverse outcomes for a number of health conditions. So this has been long-standing. What we're seeing in COVID is nothing new. And I think that's really important to acknowledge. And we need to recognize that as we move forward. And it's not only in adverse outcomes per se in how people respond and survive with a disease, it's also in that healthcare experience. So there are significant data that does demonstrate in terms of, I say significant, but actually not enough, but there are definite pockets of data which show that those from Black and Asian communities do not feel that they've had the same level of access to healthcare and positive experience from healthcare as well. And at the moment, I think you can't, well, I think for a personal note, you can't look at what's happened in the last 3 months and through this pandemic, because within and entrenched in this pandemic, as we saw the differences in ethnicity, we had the Black Lives Matter movement become really resonate and rise in this pandemic. And it has come to the forefront of the social justice and racial injustice that has been happening in society. And there's also really important to acknowledge, as we think through vaccines, etc., there's a historic feeling of mistrust between a number of ethnic minorities and healthcare and research. There are numerous examples. One is really key, the Tuskegee syphilis study, which was carried out in Alabama amongst poor sharecroppers that were African Americans. Those that were living with syphilis, when treatment came out, they weren't informed that treatment was available, and treatment was withheld from them purposely as a point of research, and they were monitored over a number of years. And so with that historical context, it's really no wonder that there is that mistrust there. So as a society, we really need to support communities to say that we acknowledge this mistrust and acknowledge that this has happened, but we move forward from this as well. Next slide, please. So with COVID-19 and ethnicity, so there were some really early signals that not everyone was experiencing COVID and experiencing the negative impact of COVID in the same way. So COVID, for a significant part of the population, for some people, it is asymptomatic. For some people, and for the majority of people, it is mild disease. And then you have that pocket of the population that experience more severe disease and, unfortunately, death. And when we looked, particularly in the UK, and we looked at ITU admissions, so ITU admissions by proxy indicate that if you've been moved to ITU, that you've got more severe disease. And if we looked at Black, Asian, and minority ethnic communities, and we looked at the number in the general UK population, it's about 13 to 14%. So you would expect, if everything were equivocal, that your ITU admissions would be of a similar percentage. But what was seen was that the percentages of Black, Asian, and minority ethnic communities was much higher. So it was higher than expected. So that gave a signal, okay, are we seeing increased negative outcomes in these communities? And these signals were also replicated across wider Europe and really quite starkly in the United States, where we are still seeing a vast difference in outcomes between Black and those of white ethnicity in America, and also particularly Latino and other minority ethnic communities in America. And within the UK, what was really stark as well was that when we looked at those frontline workers that were not only affected, but also unfortunately passed away, the significant percentage of these frontline workers were also from minority ethnic backgrounds. So ethnicity, it was signaled to be associated with an increased risk of acquiring COVID, of more disease, and also mortality as well. Next slide, please. So as I mentioned earlier, our group at Bart's Health and QMUL, Queen Mary University of London, we came together to put a study called Ethical. You're always trying to find a good name for a study. And this stands for Ethnic Disparities in COVID-19 Admissions in East London. So as I said, we wanted to understand what were we going to see the disparities that were reported in other areas within East London. Next slide, please. So within our study population, just to understand the numbers, so there were 1,996 emergency admissions to Bart's Health hospitals from the start of the pandemic until the 13th of May, and from those with a positive COVID-19 viral swab. And we excluded from this cohort 259 patients because they didn't have ethnicity data. And the main essence of our work was to understand the impact of ethnicity. So we were left with 1,737 patients in our analyses. And of these, 511 had died by day 30. So that's 29% of those that were admitted. Next slide, please. So what was really unique within our population, and why we were really obviously keen to investigate this, is that 60% of our COVID-19 population were from a Black, Asian or minority ethnic background. And to our knowledge, still around at this time, this is the largest Black, Asian and minority ethnic cohort of COVID-19 hospitalized patients that have been reported. There are similar significant levels that have been reported in Birmingham as well. And of this cohort, 30% were from an Asian and a British Asian background. And as we know in our local communities within East London, this is predominantly South Asian and predominantly Bangladeshi. And again, this is really important because when we looked and when data was coming out from national data, again, looking at those from an Asian background and seeing that there was an increased risk in those from an Asian background, it was different in different groups. So it was higher in Bangladeshis than Indians than Pakistanis. So there was a difference within the Asian group as well. And what we saw is that 75% of our patients were in the most, two of the most deprived quintiles of deprivation. So according to a postcode, postcodes can be aligned to different levels of deprivation. And within East London, we had a significant part of our population that were in two of the most deprived quintiles. And again, that's really important to acknowledge. So high diversity, ethnic diversity, and high socioeconomic deprivation. Next slide, please. And so to summarize what we saw, we looked at 30-day mortality. And I mentioned earlier that we did see that in COVID-19, that those of an older age, over 65, those of male gender, were experiencing more negative outcomes of COVID. So what we did in our study was we adjusted for this. So what we wanted to understand was that if you controlled for age and you controlled for sex, did you still see a difference in different ethnicities in terms of mortality? And we did. So the most significant difference was in those from an Asian background, but also those from a Black background as well, as compared to those of white ethnicity. So those from an Asian background were 1.49 times more likely to die from COVID than those of white ethnicity. Next slide, please. And one of the, for me, when we looked at the data, one of the things that really came out so strongly is that it wasn't only that those from minority ethnic backgrounds were dying more, but they were also dying at a younger age. So the difference in the median age of those between Asian patients that were dying than those of white ethnicity was 14 years. And so those from an Asian background were dying 14 years younger than those of white ethnicity. So it wasn't those, you know, a lot of the early rhetoric and discussions was those of that were older and frailer that were the ones that were dying. And that did happen significantly. But those from minority ethnic backgrounds, this wasn't the significant story. And that needs to be acknowledged as well. And what we also saw was that all these associations, as I mentioned, couldn't be accounted for by age and sex, and also couldn't be accounted for by associated disease, meaning things like heart disease and kidney disease as well. So compared to white patients, those from a minority ethnic background had less severe frailty and were more likely to be admitted to ICU and also be ventilated. And next slide, please. So we saw this within our cohort, and it was being seen across a number of settings. And so there was a really big national imperative and national advocacy to say, right, for the government and national bodies to really look at this in more detail and look at these signals and just confirm, are these signals a reality? And if they are a reality, what are we going to do about it? And I think it's really worth mentioning when we talk about this, because the Public Health England were tasked to look at this, and again, highlighting the importance of Public Health England, which is really important to recognise in the current context. But when we some of it is just trying to understand sometimes when as different communities have that level of mistrust is because when the data, we were told that a report was coming out, and we were told a report would be looking at the disparities and also how to respond and understand the reason why. But when this happened, the report came out, but was only really half of the story. So said that there were disparities, but didn't give any insight into the tremendous work that had been done, that had been speaking to people from these affected communities to understand the drivers of this. But with a lot of lobbying and advocacy for this, 2 weeks later, there was another report that did come out that was a that was a summary of the stakeholder insight that I've mentioned. Next slide, please. And in summary, what were the themes that came out to really think about the causes of these disparities? And structural racism and the experience of racism came out really strongly. And also the social inequalities that as being key drivers of the differences in experience, and tied into that, you know, we always think of social, but that also links to economic inequalities as well. And then there were key themes of fear, which is not unique to those from Black, Asian and minority ethnic communities, but definitely felt more acute as this data was coming out, and that whole thing of what does this mean for me? And the concerns about discrimination. So knowing that a community is more affected, not only is there fear of what happens to that community, but also will people be ostracized in the wider community because of that? And then tied into that was the issues about occupational risk and acknowledging that many people from these communities are frontline workers and therefore having that increased risk as well. There was acknowledgement of the varying impact of deprivation. And also there was a question that needed to be considered was there a biological / physiological influence that could be attributed that could have caused these differences. Next slide, please. So when we look at COVID-19 and HIV specifically and focus on that intersection, I think, and as we talked about earlier, that question, what does it mean for me, was a question that I heard repeatedly from service users at our clinics. There was this feeling that many talked about of, gosh, here we go again, experiencing that fear of discrimination and stigma, but also of something that not everyone understands. And that really compounded that fear as well. And early on, the whole issue of should people living with HIV shield or not, or shouldn't they shield? And we are very lucky in the UK, I always say, in having a really robust HIV association that is there, that advocates, but also brings messages together to kind of give that support as well, and doesn't do that in isolation. So is speaking to their partners across wider Europe to give advice for the UK. But one of the hardest things for anyone within COVID was really, what information do you trust? When you have so much information coming, you're trying to think, okay, do I trust that WhatsApp message from a friend who is in a frontline role? Do I trust those, or do I trust the news? Do I trust the website? And that was a really difficult. And I think still people are navigating how to kind of manage that and work out where to trust that information. But as I said, Beaver was a real focus, and still is, of giving that support and guidance. For services as well, I think in the HIV sector, we're always really proud that we are very innovative. We are driven by innovation and always have had to be. But within all of that, our services were predominantly face-to-face. So swiftly, really quick turnarounds, we had to move to, like majority of NHS services, to virtual by default. So having access to the services by phone or video, if that infrastructure was there. And again, that changes the dynamic really significantly. And having to organize click and collect and home delivery for medication as well. And I think as well that whole concept of peer support is pivotal within our sector. And that shift to virtual, for many people, that face-to-face peer support is the only space and the only safe space they have to talk about HIV. So that was suddenly pulled from them. And whilst we can, and services were maintained virtually, it is a very different experience. Next slide, please. So when we look at COVID-19 and the intersection of HIV and ethnicity, we are still learning, and information is coming out. And I think, as I've said, one of the difficulties is really trying to understand how to package this information and what it does really mean. And earlier on in the pandemic, when I say earlier on, it feels such a long time frame. It's only probably like 2 months ago, where there was there were differing outcomes in some small case series when people were looking at the outcomes in people living with HIV and the impact of antiretroviral therapy. And a group at King's looked at 18 people that were living with HIV that had been hospitalized and compared these outcomes to the whole HIV outpatient cohort. And 17 of these patients were Black, and of the 18, 5 passed away, 12 were discharged, and 1 remained an inpatient at the time of reporting. And their conclusion was that Black people living with HIV appeared to be at substantially increased risk of severe disease. And again, adding into that signal of increased risk of adverse outcomes. Now, there was a lot of acknowledgement and definitely a lot of fear of people thinking, right, we were told there wasn't an increased risk and there seems to be now. I think the message was and still is that there is ongoing scrutiny and surveillance and recognizing that this was as a very small case series, important nonetheless, but we can't bridge and build all our decision making on this. And what is really important is that we continue to watch and explore any signals and respond to the signals if they come out further. Next slide, please. And I wanted to bring up something that just really hot off the press as well in the last week or two, which again was added to this concern of, is there an increased risk of COVID-19 and of adverse outcomes with HIV? And this study was for using an open safely platform, and this platform was put together. It's a really large platform that was an amalgamation of UK primary care data that is linked to national death registrations, and the number of people within this is millions, so it is a significant cohort. Next slide, please. So this group then looked at the primary care data and looked at those that were coded to be living with HIV, and then looked at outcomes in this group. And what they reported to find was that there was an increased risk of COVID within those that are living with HIV. Next slide, please. I've just highlighted what was put on the Beaver website because I think it was really well done and really highlights the importance of acknowledging data, but just kind of putting that into context. So yes, initially it is concerning to see this increased risk of death for people living with HIV, but there are a number of things that we need to be cautious of when interpreting this data. First of all, the data, as I said, is mainly primary care data. And primary care data, we know in terms of errors of communication and how things are recorded, is that HIV infection is not always, and for many, either incomplete or inaccurately coded within primary care. And that is some work that is acknowledged and continually being worked through, but it isn't an optimal way of picking up and accurately recording those that are living with HIV. Also, the primary care data that they used was representative of many populations across the UK, but there are many different computer systems that are used with primary care. And one of the biggest ones wasn't included in this data set. So there's a big pool of patients that have not been included nationally. And it is possible that those living with HIV were included in the data set, but may have had different risk factors for COVID-19 and poor outcomes from COVID-19. So this data is important and suggests a signal, but again, what's important is that we continue to monitor and collaborate and bring data together and interpret it responsibly and then relay it to the wider community. And BEVA have emphasized that that is ongoing work that is happening in the background there. Next slide, please. So as I end, I just wanted to emphasize again this. When we talk about the data that we're seeing in terms of COVID, in terms of ethnicity, and in terms of HIV, yes, it all intersects, definitely. But also, I think that as we look after each other in our different communities, in our different networks, and Greg, I think you put it really nicely when earlier you were saying, right, you know, what can I do to help? What can I do to support? And many people think that. I think that it is also recognizing as we support one another that everyone is having their own intersectional experience of COVID, and we need to be mindful that as we look after each other, as policies are developed to look after people in this setting, that we make sure that we build systems and support for everyone, and we make a conscious effort to understand different people's experiences. Next slide, please. And I can't talk ever, but not bringing in the intersection of gender within this as well, and recognizing this is a really important intersection here too. Next slide, please. So what next? And I think that if anyone who knows me, one of my favorite words is intentional. I think that whenever you respond to anything that is happening, it's got to be an intentional response. So I think that I would say that there needs to be intentional consideration of what is happening, intentional surveillance. For many, if people don't feel seen or feel valued, they worry that actually are the powers that be thinking of me and considering me in policies and are monitoring what is happening within different communities. So there needs to be intentional consideration. There needs to be intentional advocacy based on the information that we have. A perfect example is what happened with the signal of ethnicity in COVID. There was a real national swirl of like, what is happening? We need clarity, we need information. And that advocacy that we know so well within the HIV sector, I really believe, you know, many sectors need to learn from that and really drive that advocacy. And then based on that, we need an intentional response to that. Next slide, please. So for me, I think that it's really important that, again, when you look at the data, numbers give you something, but they don't give you the whole story. And so doing your quantitative analyses and looking at data and numbers and how many are affected is so important. But what also is really important is that qualitative element. So understanding, listening and speaking to people and getting their experiences and really actively exploring the lived experience and doing this as well to leverage that lived expertise. Because if we are looking at how do we get the messaging out there, how do we support people, if we don't understand the way that we need to communicate, how, where, what volume, we won't achieve what we need to achieve to really get on top of this virus and move to our new normal, as it were. I think there are a number of occupational considerations. So as I've said, those from Black, Asian and minority ethnic communities in whatever role and in whatever community anyone is in, making sure that they are given a psychologically safe space to talk about their risk, and also that objective risk, but also their subjective risk as well, and how they feel about their risk, so that employees can create a really enabling environment so people feel safe to keep on providing their role. Because most people in key worker roles, as we've seen in the supermarkets, police, social workers, etc., people want to keep working, but they want to do so safely. And that also within the kind of PPE provision as well. And my last point really is that I've used it, we all use it. We're all trying to find a better term of the term BAME and Black, Asian and minority ethnic communities. It is a swirl and covers the most heterogeneous, diverse communities within that banner. And each group and each subgroup lives and has a very different experience. So it's really important that as we understand different communities and as we shape any responses, we make sure that we acknowledge these significant differences. And it's just also making our governing bodies and those that develop these policies accountable. And that is in our advocacy. So there is so that we ensure that there's truly an intentional response. I think I'll end there and then we can go through any questions. Thank you.
Vanessa, that was fascinating and very insightful and so very important because it really highlights the discrepancies in our society. I think we were all aware of the disparity with different ethnicities with COVID, but to see the data laid out was really quite startling. So I think as a nation, we've got a lot of work to do, but thank you on behalf of Positive East and all our clients. Thank you so much for a really fantastic presentation, Vanessa. It was really,
thank you. No,
thank you.
I'm really happy to do it. Great.
Okay, so for those of you that are service users with us and you've registered to come along to this event, Vanessa and I will be remaining in this Zoom room so that we can ask you questions. So we'll have a 5-minute break and so give you time to log in and we'll see you soon. If not, and you need any services, peer support's available at Positive East, as is many other services. So if you're struggling with COVID or you're struggling with HIV, come and see us and we'll see you very soon. Thank you.
Greg, and I just want to say, actually, I've been, just to kind of give a shout out to you guys at Positive East, I think it's been a real template of how to do it. For our service users, it's so many have commented that the fantastic support that you've maintained through this period, and it's been no mean feat. So thank you to you guys too as well.
Vanessa, it's very, very kind of you. Thank you so much. We really appreciate your comments.